My topic is the metabolic complication of rheumatological disease. So rheumatological disease mainly classified three important definition. One is WHO, another is ATP, another is IDP group. So among these three important groups, so the component of the all metabolic syndrome is same. So this is the very important criteria how to define the metabolic syndrome in this patient. Next slide, please. So the major component of the metabolic syndrome include resistance, insulin resistance, central obesity, dyslipidemia, and hypertension. So it is accepted that the concept of metabolic syndrome identifies the central obesity with increased risk for cardiovascular disease and type 2 diabetes mellitus. Patients with rheumatological disease at increased risk of mortality and coronary disease is the leading cause of death among such patients. Next. So among the various rheumatoid disease, the several disease like rheumatoid arthritis, osteoarthritis, systemic lupus erythematosus, ankylosing spondylitis, psoriatic arthritis, and systemic sclerosis and elastic gout has been associated with an increased prevalence of CVD. For example, CVD is responsible for almost 50% of excess of mortality in case of rheumatoid arthritis. Next. So despite the different pathogenesis and symptom of rheumatoid arthritis, systemic lupus erythematosus, psoriatic arthritis, and gout, the presence of inflammation is very important features and same in all diseases. So inflammation is mainly key factor for the development of complication of rheumatological disease. So metabolic complications are reported with this inflammatory condition and non-inflammatory condition like knee osteoarthritis sometimes associated with metabolic complication because of high BMI. Next. Recently, the immunometabolism has been widely studied in metabolic diseases. That study mainly focused on 6 major metabolic and pentose phosphate pathway and amino acid and fatty acid oxidation and fatty acid synthesis. So there are so many research on lipid metabolism has been going on for years, and the output of the research, for example, dyslipidemia is associated with CD4 cell activation, complement medial renal damage in the lupus. Next. Statin, another output is statin suppress the secretion of the pro-inflammatory cytokines by macrophage and T cell in RA patient. In SSC and fibrotic disease, lipid metabolism was a key mediator in the activation of fibroblasts and immune cells. In addition, adipose tissue is correlated with oxidative stress and participates in vascular damage. Next. Another output of the research, so dyslipidemia is characterized by lower HDL and higher level low density lipoprotein, triglyceridemia, and total cholesterol is commonly found in rheumatoid disease. And high level of LDL and abnormal HDL means dysfunctional HDL, is the mainly responsible for increase of the atherosclerosis and end organ damage, such as central nervous system and kidney disease. Next. So various studies have been shown that the pathogenesis of metabolic syndrome involves in inflammatory process, and pro-inflammatory cytokines such as tumor necrosis factor alpha reduce the activity of insulin So it developed the insulin resistance. Another factor, interleukin 6, also responsible for development of insulin resistance. So inflammation has been associated with the obesity as well as elevated level of LDL and triglyceride and reduced level of high density lipoprotein, which is responsible for the development of metabolic complication in case of especially SL. Next. It seems that abnormal abdominal obesity in patients with rheumatoid arthritis and lupus, hypertension and obesity in psoriatic arthritis, and triglyceridemia and hypertension in gout are important components in metabolic syndrome that require more care for this patient. Next. So inflammation is the key features of obesity and type 2 diabetes, while patients with RA and SLE and have a increased risk for CVD. So RA patients have fourfold increase in cardiovascular event. CVD are the most common cause of death, with approximately 40% of death in RA patients attributed to cardiovascular diseases. Next. Patients with SLE have high risk for myocardial infarction because of dysfunctional HDL responsible for subclinical atherosclerosis, so develop myocardial infarction in young SLE patient. Another 25% of death in SLE are attributed to CVD morbidity, which is leading cause of the death. And most importantly, all the symptomatic coronary disease is not uncommon, but subclinical atherosclerosis assessed by single photon emission tomography is much higher and observed in up to the 42% of the asymptomatic patients in SLE. Next. So the premature atherosclerosis is the main component for the development of metabolic complication in RA, and the chronic inflammation is the main responsible for premature atherosclerosis. May alter the how it developed, may alter the vascular endothelial biology to prothrombotic and protherogenic and proatherogenic state. In SLE, in addition of premature atherosclerosis, the other factors like anti-phospholipid antibody and treatment like steroid is also responsible for development of premature atherosclerosis in case of SL. So pro-inflammatory HDL, PI-HDL found 44.7% in case of female SLE patient and 20% in case of female RA patient, but only 4.1% of the healthy women. So for this reason, the metabolic complication is more common in SLE and RA in comparison to control patient. Next. So this is the very important table. 3 important studies done on rheumatoid arthritis patient. First one is that total participant is 200 and the women predominant for 74%. But based on the NCP criteria, so 44% metabolic complications seen in case of rheumatoid arthritis in comparison to control 41%. So that is not significant, because in case of rheumatoid arthritis, all patients are low disease activity, have low disease activity and with normal BMI. But same thing is last study, that is Desan et al. But Chow et al. Study is the patient study was done on rheumatoid arthritis on patient having more disease activity. So here we get metabolic complication more than in comparison to control. So authors conclude that so modifiable factor like obesity and disease activity should be targeted for prevention of CVD in RA patient. Next. So the prevalence of metabolic syndrome in case of osteoarthritis studied over 1,350 patients and shows metabolic complications 62.5%. But same study also shows the incapacitated individual, the osteoarthritis, 90%. So another study reported the prevalence of metabolic syndrome is very high in individual with knee osteoarthritis, and its attributable factor was high BMI. Next. So gout is a simple inflammatory arthritis characterized by hyperuricemia, commonly associated with the hypertension, hyperglycemia, obesity, and dyslipidemia. And authors found that overweight, type 2 diabetes, and hypertriglyceridemia is significantly higher in population with gout than control, regardless of the age group. So prevalence of arterial hypertension are higher only among those in the highest age group. So the complication in metabolic complication in gout, 43 to 62% in comparison to control, is very high complication in case of gout. Next. So this is the another, the primary Sjogren syndrome is commonly associated with so many metabolic complications. Type 2 diabetes and hypertriglyceridemia is very common if extragranular findings is associated. Next. In ankylosing spondylosis, the metabolic complication commonly prevalence 45 to 45% in comparison with control 10%. But patient on anti-TNF therapy, despite the metabolic syndrome is very high in case of PS, in case of psoriatic ankylosing spondylitis. So metabolic syndrome is always associated with very high disease activity. Next.
Could you please sum up? Time is up.
This is okay. So, okay, so within 1 minute, okay, I summarize exactly. So this is the common thing. So common disease except RA, the reference. Hello. Hello. So
you are audible. Carry on.
So this is the complication, the frequency of metabolic complication in various rheumatological conditions, and the with reference. So already I told you in before. Next slide, please. So I conclude my lecture. The prevalence of metabolic syndrome in rheumatological disease was found to be range from 14% to 62% using classification either WHO or NSCP. Majority of the studies demonstrate that the frequency of metabolic syndrome was higher in patients with rheumatological diseases than in control population, suggesting that either the presence or the treatment of the disease influence risks of developing metabolic syndrome. Next. So the coexisting of the rheumatic disease and atherosclerotic disease increases mortality of rheumatic diseases. Statin agent not only lower the atherosclerotic but also immunomodulator of rheumatic disease. Lipid metabolism can directly influence T cell and macrophage. Next. So the take-home message that metabolic syndrome is associated with increased cardiovascular risk and has been studied in some rheumatic conditions: gout, osteoarthritis, systemic lupus erythematosus, rheumatoid arthritis, Sjogren, and ankylosing spondylosis. Prevalence of metabolic syndrome is higher in rheumatological diseases, 14% to 62%. Disease itself and treatment may implicate in the risk of appearance of metabolic syndrome.
Thank
Next.
you, sir.
Thank you.